for his presentation on Dr. Boramanis Endo expression technique of nucleus management in manual SICS.
Good afternoon, everybody. Sorry,
Dr. Dhaliwal needs no introduction.
I'm just
binary and
running back from LR1 because the mail that I received said just cases was supposed to be in LR1, so I was sitting there.
Nice, we did not miss your talk, sir.
So I'll not be talking. The video has a voiceover. Manual SICS in premature cataract, in mature cataract, Dr. Boramanis Endo expression nucleus. Sound, please. Sound.
Sound on.
Audio visual, please increase the sound. Sound is not coming.
Greetings from my infirmary. Today we will present to you a case of senile mature cataract in a diabetic patient.
दोबारा चलाऊं?
Greetings from my infirmary. Today we will present to you a case of senile mature cataract in a diabetic patient being taken up for a superotemporal manual SICS. The surgery starts with minimal conjunctival peritomy and cauterization. A partial thickness scleral incision measuring 4.5 mm with an aim to neutralize 0.75 diopters of astigmatism is marked, supplemented with Blumenthal side cuts. Ametropia is planned for this eye. Sclerocorneal dissection starts in the center of the incision with a crescent knife, moving towards the peripheries, dissecting the tissue as you come back. The side pockets have been designed to accommodate nucleus and to prevent an astigmatic surprise. Side port entry is made at around 90 degrees from the main tunnel. Capsule is stained with trypan blue and anterior chamber is formed with viscoelastics. A large continuous curvilinear capsulorhexis is what we aim at in such cataracts. We prefer to stay just under the pupillary margin with our cystotome. If rhexis tries to extend in such cases, it has to be detected early, as once it crosses the line of control there is no rescue. And we can't afford extension beyond the equator in any case, especially in diabetics. This aids in easy prolapse of the nucleus-epinucleus complex without any stress on zonule or compromise to the posterior capsule. Main entry is made with 2.8 mm keratome. A gentle hydrodissection is done with 26 gauge cannula and the nucleus is tapped on the opposite side to release the trapped fluid. Nucleus is cartwheeled out of the bag. We do not perform nucleus tumbling where zonule are suspected to be weak. Visco is injected to coat the endothelium and around the nucleus and nucleus is engaged into the tunnel. Now, the nucleus is large and our tunnel is smaller, so it would not deliver with visco expression. In this situation, we inject some visco into the AC through the side port and push the nucleus from inside, through the side port with the blunt dialer, and the entire nucleus is expressed in toto. The entire process is safe to the endothelium as the nucleus is imposing the pressure on stroma of the cornea and sclera and not the endothelium. Engagement of the nucleus is the key factor to perform this maneuver. This technique of nucleus delivery was taught to me by my mentor Dr. Boramanis. So I like to call it Dr. Boramanis Endo expression of the nucleus. Anterior chamber is formed with viscoelastics. This is an aspheric hydrophilic IOL that we implanted with IOL holding forceps only. In SICS there is no need to squeeze the lens into an injector. Take care that leading haptic goes into the bag. The trailing haptic is gently guided into the bag with a button dialer or visco cannula itself. IOL haptics should never be left in the sulcus. This design of IOL will lead to severe iritis or lens iris touch related complications. A through visco wash is mandatory. Clear every bit of visco from any part of the eye, the anterior chamber, posterior chamber, from behind the IOL and lastly from the endothelium. There is absolutely no need to go behind the IOL with the cannula in every case. Just gentle tapping and rotating the IOL with the Simcoe's cannula will bring out the visco to the anterior chamber. Side port hydration is done to make the wounds watertight. Titrate the IOP so that the wound doesn't gape. Repose the conjunctiva well. Do not leave the scleral wound bare, which will increase the chances of wound site infections and foreign body sensation in the post-operative. Intracameral moxifloxacin is injected. We also put some drops of moxifloxacin in the conjunctival sac and rescrub the lashes with 5% povidone iodine before dressing the eye. Thanks for watching.
I present this video here for the reason Dr. Boramanis had been doing the surgery for a long time, but the surgery had
Greetings
no name.
from my infirmary. Today we
The surgery had no name, so Vikram christened it Dr. Boramanis Endo expression of the nucleus, and this appears in the IJ also now.
Thank you, sir. It was a very nice demonstration of a wonderful technique. Thank you.